Ready to rock and roll. Let's see, Elena Matab, Zainab, when do you guys want to unmute and let me know if everything looks good? Presentation screen, sound okay?
Yes, Dr.
Thank you. Awesome. Okay, welcome to everyone, and I will say good morning, good afternoon, or good evening, depending on where you're tuning in from. Thank you so much for attending. I know it's it's unusual. It's a Wednesday, and it's an odd hour no matter where you are, likely. But if I don't have an audience, I can't do the conference. We are very few in number this morning, but we are very powerful. Okay, I would like to welcome everyone to the University of Texas MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for November 18, 2020. I would like to remind everyone I am recording this conference, and what I may do is send it out to everyone that was on the invitation list, the recording, if I am successful in recording it. So if you want to have a second look for those of you here and then those who couldn't attend, I think I do have the chat function working. So if you want to chat your answers to the questions, please do so. I encourage you to participate, to guess, to try, to fail publicly. Now, you're not failing as public as I would like. If you miss an answer, I would like it to be in person, like we used to have at the 16-headed microscope, but that's okay. Chat fail is the next best thing. Okay, adventures in neuro-oncologic diagnostic medicine. Let's go. We always start off with a warm-up. So let's do, first warm-up is going to be an MRI warm-up. And here we go. Hey, Pedro, your video's on. That's it. Good thing. Thank you, Dr. Diaz. We have Pedro Diaz in the house, expert neuroradiologist at Texas Medical Center. Okay, here we go. I want a diagnosis. Would someone like to chat a diagnosis? I'm going to give you just a few minutes. Focus. Just an approximate. I mean, just, it doesn't have to be the exact, okay? Okay, you ready? I'm going to move on. We're slow to chat. It's okay. All right, diagnosis. Anyone? Oh, my goodness. Sanjay Singh. another senior don of neuroradiology. Nailed it. Yes, it's pineoblastoma. Good job, Sanjay. I mean, truly impressive. Okay, now, here, let's get rid of that. So let's have a look at it again, all right? Now, if you focused on the scoliosis correction, that was the point. I designed this so that you would be looking at those pins and rods and focusing on it and thinking, well, what was it? Was it chordoma, the thoracic thoracolumbar cord, or yada, yada, yada. That was the point. Now, the reason why that Sanjay and probably Pedro Diaz nailed this so quickly is because they are trained to be thorough. Pathologists are not trained to be this thorough. I imagine many people are focusing on the spine, a scoliosis correction, and totally forgot to look at every image and to look at the top, the bottom, the right, the left, edges, because that's where the lawsuits hide, and that's where the damage to your patient lies, is in the border, at the edges, right? All right? So now look, let me point this out really quickly. What is the pathologist's equivalent to not seeing this pineoblastoma, to ignoring the top of that far left? What's the pathologist equivalent? The pathologist equivalent is, let's say you get a slide folder with 10 slides, and 8 of them have these giant chunks of tumor, and 2 of them have these little tiny pieces. And you don't look at those because you're thinking, why should I? I have all of these slides with a giant chunk of tumor, and I take one look, at the first big slide, and I make a diagnosis, meningioma, glioblastoma, whatever, and then I said, I'm done. I don't even look at the rest of the slides, much less those little slides, and you miss so much. And sometimes really important things when you do that. That's the pathologist equivalent. That's why I always say when I'm teaching our fellows, residents, etc., back when I was at Duke, look at every slide, look at every piece of tissue on every slide. Learn from the radiologist. Okay, what is it called, by the way? The radiologists have this wonderful term for what we're talking about here. You take one look at these films, you see all those pins and rods and screws, and you make a snap diagnosis, and you are done. They call it satisfaction of search. I was looking, I found a big abnormality. Yeah, got it, nailed it, done, move on. That is so poor, and that is so far from excellence. It's ordinary. That's why there's a term for it, and it's talked about so much. We need this term in pathology, satisfaction of search. You know, what I usually say, how I explain it, is you look at the first slide, you make a snap diagnosis, and you go brain dead. You know, which is a very appropriate term for those who do that, because you're not being thorough. Did you like that? Huh? Okay, let me ask you a question. Was this a fair challenge? I mean, honestly, what do you think? Is it okay? What was it fair? Okay. Some of you who have been attending the conference for, you know, a year or two or more know where this is going. Yes, Kristen Huntoon says, yes, it's fair. Yes, it's fair. Okay, we're going there. We are absolutely going there. Who recognizes this figure from history? I'm not talking about the actress in the movie. Who is this character, and what is the significance, and what is the best quote? Again, coming from Wonder Woman, coming from the movie, what is the best quote, in my humble opinion, from the movie that is apropos to what we are discussing, the satisfaction of search, this expecting that you take one look, a quick look at a film, a quick look at one slide, and you're so good that you think you've nailed it, and you move on. All right, Andrea Gilbert, yes, absolutely. Dr. Gilbert was paying attention when she was a fellow here. Yes, this is Antiope. All right, who is Antiope? Well, there's the Wikipedia entry. All right, Antiope, from the movie, from history, Amazon general, legendary warrior, trainer of Diana, and this is one of the best scenes in the movie, the very first part. The first part, when Diana's growing up, in my humble opinion, that's the best part of the movie. You could just watch that and call it a mini movie, and you're done, and here it is. So after Antiope actually knocks Diana to the ground because Diana thought it was over, right, and we're relaxing in between, and Antiope blasts her, and she says, you expect the battle to be fair? The battle will never be fair. It will never be fair. So I will work as hard as I can to set these traps up, like the one I just showed you. Yeah, I'm going to work as hard as I can, but no matter how hard I work or devious I can be, I can never be as devious or unfair as nature, as cancer, as all of these other diseases will be to you in your career as a diagnostic radiologist, in your career as a surgical pathologist. So another famous quote, it's better to bleed in training than die in battle, and that's what I want you to do in these conferences. That's why I use the chat function. Commit yourself, all right? If we were actually in person, you know, it would be even better. So commit yourself, because that way you will remember. Look, if you humiliate yourself in public, you know, you make a wrong answer and you're so embarrassed because there's something obvious and other people knew what it was, that's going to engage the hippocampus and the limbic system. It will engage emotion, and you will never forget it. And that's a good thing. That's what we're striving for. Okay, you like that? Okay, let's move on to MRI warm-up. Number 2, we do something a little different here. Now, this is going to be a bread and butter. Bread and butter means it's the radiologist equivalent of the Aunt Minnie. You know, you see your Aunt Minnie in a mall in the street. Well, we don't go to malls anymore, but, you know, you see your Aunt Minnie in a crowd of people, and you know instantly you recognize it. It's just like that. Well, this is going to be a bread and butter. But, you know, there's different ways to do this. It's a bread and butter diagnosis, but what I want is a differential diagnosis. And you can just give me what's at the top of your differential diagnosis. You don't have to, you know, list the whole list. Just give me one, all right? That's what I want. But I'm going to make it a little bit more challenging. I'm going to make it professorial challenge. Now, look, I've already mentioned that we have several expert neuroradiologists, Sanjay Singh, Pedro Diaz, in the house. I have to have something for them. All right, as well, for everyone, right? So this is one that's sort of at their level, but I want everyone to try it, all right? I want a differential diagnosis. Ready? Here we go. Just give me one entity. I'm watching the chat. One entity in your differential diagnosis. Give you a few more seconds. Yeah, Andrea Gilbert, excellent, very good. All right, Darshan Trivedi, good job. Andrea and Darshan, both former neuropathology fellows here in the Texas Medical Center. All right, and Pedro Diaz, of course, Dr. Diaz, and Elena Zunarelli. All right, Neuropathologist in Modena, Italy. Great job, Elena. All right, here we go. Let's move on. There's the lesion. See, the point was, could you see it? Did you see the lesion, right? Now, the neuroradiologist is going to be all over this because they're trained, again, to see the nuances, all right? Here's a, look, is that better? Do you like this better? Okay, for the pathologist, quick question. What are these two sequences? And why is the lesion more obvious on the second? You see how the CSF is bright, hyper intense? So it's T2. These are both T2 flavors. What is the difference between the two scans? Pathologists want to give it a quick guess. What's the difference? Okay, yes, Andrea Gilbert, very good. T2 and a fat sat. Yes, the two sequences are actually a T2 stir and garden variety T2 stir. What is that? What does that mean? Here we go. Short tau inversion recovery. Now that inversion recovery it's fat suppression, right? Now, does that ring a bell? Inversion recovery. Does that remind you of any other sequence? Let me think. How about flare? See the IR? Oh, could it be the same? Yes, absolutely. Fluid attenuation, inversion, recovery. Flare suppresses normal water fuel, cerebrospinal fluid, all right? Whereas the short tau inversion recovery suppresses the fat signal, which can increase conspicuity of lesions and alter differential diagnosis in many instances. Okay, here's the full sequence, just so you can also see the T1 and the T1 with contrast. I think the T2 and T1 with contrast, the lesion is most obvious. It's less obvious, but still clearly identifiable on the T1 without contrast, but I think it's the least conspicuous on the T2 stir, which is why I chose it for the professorial challenge. All right, now again, a wonderful term from the world of radiology, conspicuity. Conspicuity, it means, is it conspicuous? The degree of conspicuousness or conspicuity. How easy or difficult is it to see a particular feature? And it's the same in pathology. We have examples that way. Things that tend to alter conspicuity in pathology. How about cauterization, cauterized specimens, water artifact? You know, when the surgeon or whoever circulator accidentally puts the little bits of tissue in water instead of normal saline, you get all these artifacts. Conspicuity, wonderful term. Okay, differential diagnosis. Okay, we've been through this many times, and we will keep doing it because we always have, well, usually we have one or two new people. Well, I'm going to call it the big five, all right? Schwannoma, myxopapillary ependymoma, meningioma, paraganglioma of the phylum terminale, and a solitary metastasis, which can be a drop metastasis, dropping from where? From above, posterior fossa, supratentorial tumor, sheds into the CSF just for gravity, sitting up, standing up, circulation of the CSF. It's going to go to the spinal cord, and it's going to end up in the bottom of the fecal sac. That would be drop metastasis or a hematogenous. That also happens. It's a garden variety hematogenous metastasis, yes, to the lumbar cisterns, to the conus, to the phylum, to the roots, to the dura, et cetera, okay? Now, for meningioma, this is a non-dural based tumor. So we're talking about the differential diagnosis of a non-dural based tumor. Always remember this clear cell sclerosing variant of meningioma, which these are not dural based. They are not dural based in the lumbar cistern. So it always has to be there. So here's one of the lessons in case you had forgotten. We've covered this a couple of times, at least in the conference, I think over the last year. Do not forget to include clear cell sclerosing meningioma in the differential diagnosis of a non-dural based solitary lumbar cistern mass. Now you can just call it clear cell meningioma because it is a clear cell WHO grade 2. That's fine. I put in the sclerosing because a majority of these are not solid clear cell, sort of like mimicking oligo or renal cell carcinoma. A majority of these tumors are mostly collagen. That's the sclerosing, and the clear cell are little single cells and small nests of clear cells among the massive, bulky collagen bundles. That is the normal histology of clear cell sclerosing meningioma in the lumbar cistern, right? And we talked about that. If it's unfamiliar to you, just Google it, do an image search, etc. And good. Okay, this is our patient under consideration. Again, I say this at every conference that these cases are not drawn from the literature or from the web. These are drawn from MD Anderson cases, and I'm not going back into the files from last year, the year before, last 10 years. This case, all of the cases I'm presenting today have come to attention during the last, 2 weeks since I gave the conference. All right, this is the tumor. Look at that gross photo. Let me ask the pathologist, wouldn't it be nice if you could put together montages like this in the lectures that you give of your own original material instead of having to go to the web? Well, the only way that's ever going to happen is if you photograph them, if you take the time to do it. Quick question, do you think that the neurosurgeon asked for a frozen section on the? Yes, absolutely. Can you tell that I took tissue? No, you can't tell. Why? Did I delay the frozen to take a photograph? Absolutely not. The patient always comes first. So where is the missing tissue? It's on the bottom. It's on the obverse side of what you're looking at. You can't see it because I cut a thin slice from that aspect, which was the least visually appealing aspect, did a smear, did the frozen, all right? And at the same time, I asked our assistants to, call medical photography, so they're on the way, the frozens get going. Understood? But if you don't take the time to do that, you're never going to have these photos. And I've said this before, they are gold. They are absolute gold. Histologic, a single H&E, you can generate 2.5 billion unique photos for publications, book chapters, all of that. For a gross photo, you can only publish it once, and then if you want to use it again or someone asks you, yada, 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 you have to give attribution, which is fine, but it's not the same as showing original material. You like it? All right, here it is writ large. How is that? This is what a professional medical photographer can give you. Oh yeah, you can snap a picture with, we have automated camera up and frozen, there's a stand, something like that. I know people use iPhones to do it, questionable, I know. It's never going to equal this. What you're going to end up with typically is this big bloody green towel, right? And it's just with a partially out of focus, where are you going to get a black background like this? How's that going to happen? You're going to have to Photoshop it? Okay, point made. Got it? Okay, here we go. Histology. So what is the diagnosis? What is the diagnosis in this case? We have that beautiful 5 things, right? Okay, let's have a look. This is the whole slide imaging. And here we go, higher power. Looks a little spindled, doesn't it? All right. And look at the blood vessels. See the blood vessels? See all that collagen? This is hyalinization or sclerosis of the blood vessels. It's always an indicator of chronicity. So this is not a metastasis of a high-grade malignant grade 4 tumor. This has been here a while. This is schwannoma. So this was a schwannoma. Now, by the way, if you went with myxopapillary ependymoma, because it looked kind of boxcar, or flattened, schwannomas can do that. They do look like that, the myxopapillaries, most of the time. But guess what? This was a schwannoma. Okay, listen. If you and everyone that ventured a guess went with myxopapillary ependymoma. Okay, and that is appropriate. That's totally cool for the look. I say it's appropriate because that's a morphology. But schwannomas are actually numerically more common than myxopapillary ependymoma. So maybe next time, go with, you remember the rules of the differential diagnosis. You're supposed to list the most statistically likely, common, thing first, and then the next, and the next, and the next, and sometimes there's ties, etc. And it's based on the data that you have, and of course the data changes. Remember the 8 Venn diagram sphere, 8 spheres of data, and as we add another sphere of data, it narrows and modifies the differential diagnosis. Okay, schwannoma, WHO grade 1. And there it was. It was number 1 on our list for a good reason. Okay, hang on a second. So this is the differential. Don't forget clear cell sclerosing meningioma. Everybody got that? I think that's all the points that I wanted to make. I mean, it's just a warm up, right? we're still just warming up. I have real challenges coming up in just a minute. Okay, I don't think we've done this before as a warm up. I have not been emphasizing smears enough. Cytologic preps, I should say, enough in the conference. That's going to change. I'm going to see if I can include a smear in every conference we do. Now, the reason for that is back in the day when we were meeting in person in the 16-head microscope room with the monitors and all of that, I used smears a lot. The reason why I have not had them so much in the COVID era is because we typically do not digitize, scan in smears because of the varying thickness. When the scanners have a focus plane, right? So in a smear, if it goes from thick, where the piece of tissue was when you did the crush, and is thinner, 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 then the thick is going to be out of focus, this sort of thing. However, the majority of smears, if they're well performed, there will be areas that will be in focus that are very usable, and I've started doing that on select cases that we will be able to use in this conference. Okay, so let's have our inaugural smear warm-up. All right, brief review. There's only 2 types. of smear patterns. Now, we're talking now about smears as opposed to touch a drag, et cetera, et cetera. Actually, I'm going to show you a drag, but only 2 types of patterns that you see with the naked eye. You can actually pretty much see with the naked eye before you put it under the microscope, and that's chunks and or clusters, big clumps, chunks, and single cells. The chunks and clusters are going to be obvious to the naked eye, right? Clump, clump, clump. The single cells are going to be this beautiful, smooth, even spreading out of the smear. Okay, let's look at chunks and clusters first. Why? Why do some tumors and other pathologic processes smear in chunks and clusters? Because they don't want to let go of each other. Why? What's the biologic reason? Well, how about intercellular junctions, spot wells, like desmosomes, metastatic carcinoma, great example, smears in chunks and clusters. Now, of course, if there's necrosis, then you're going to get this fine background, in the background, but the viable tumor cells themselves are going to be chunks and clusters. The other reason, if the cells have long intertwined cell processes, like fibrosarcoma, for example, the cell processes all tied up, or how about both junctions and long processes? Think of fibrous meningioma. Yeah, has both desmosomes and long processes. All right, those are chunks and clusters. All right, let's do a challenge. We're actually going to do 2 cases. So that's why I'm calling this smear case number 1. All right, this is the whole slide, the whole thing, digitized image. What do you think? That's chunks. Okay, and yeah, wow, everyone is responding. Wow, I've got all kinds of schwannoma, Sahara Cathcart. I like it, Sahara, playing it safe. Spindle cell lesion, I like that. Okay, good. And most people, Barbara Sains, welcome, Barbara, going with schwannoma. All right, here we go, higher power. Yeah, you like that? Look at those little bridges. Aren't those interesting? The little bridges. Yeah, I like that. A little bit, one more, higher power. Okay, here's what you should be thinking for your differential at this point. Schwannoma, absolutely. But don't forget fibrous meningioma. Fibrous meningioma smears will look virtually identical to schwannoma because it's spindle cell, chunks and clusters, these little bridges that you're seeing, okay? But everyone went right on the money, okay? And here we go. This is the FFPE, look the same on the frozen. What you're seeing here, Veracay bodies, absolutely done and done. So this was a true bread and butter. Real bread and butter. Vestibular schwannoma. The neurosurgeons still love to call it acoustic neuroma. That's what this one came. They all do, which is fine. I think that's totally fine as long as we, as neuroradiologists and neuropathologists, pathologists, know that it's vestibular schwannoma. Now, they're not all vestibular. In the cerebellopontine, they're not all vestibular. Right? I mean, other nerves, all of these other nerves can give rise. And is there such thing as true as an acoustic? Yeah, absolutely, they do. And we talked about all those fine divisions, but all of those together are so much rarer than vestibular schwannoma that vestibular schwannoma is number 1. Okay, excellent. And there's the actual report. Cranial nerve, left cerebellopontine angle, craniotomy, resection, schwannoma, WHO grade 1. Okay, ready for smear case number 2? Okay, here we go. Yeah, I've got Andrew Gilbert, ice cream cone sign, and Barbara Sains, the snow cone. Right. Hey, is it okay? Let's go back. Is it okay to say that this tumor in the cerebellopontine angle? Let's say you're a radiologist and you describe it. Contrast enhancing, avidly solidly contrast enhancing mass in cerebellopontine angle growing into the internal acoustic canal. No, it's not okay to say that. Because it's the other way. Correct, Darshan, Dr. Trivedi, it grows out. Yes, Dr. Gilbert. They all start distal, all right, distal to the CNS-PNS junction, and they come from Schwann cells, not oligodendrocytes. Okay? Yes. Okay. All right. Moving on. Let's see. Smear case number 2. Ready? Now this is well, actually. I'll let you study it for a second. The big splotches or air bubbles, it's a smear, and you can see one big chunk there. That's elevating the cover slip so that it won't lay flat, so there's bubbles when you put it down. That's okay. It happens. No big deal. All right. Okay. And I want to ask, here's the first question. What type of cytologic prep is this? I know I'm calling it smear, and we're talking about smears, this is actually not a smear. A smear, the way we use it, is a crush and smear. You crush and then smear. What is this? Yes, it's a drag. Very good. Andrew Gilbert, drag. Zainab Harb, drag. Yes, absolutely. This is called a drag prep. Here's what happened with this case. This is mine. These are all my cases. You know, you pick up the piece of tissue with the forceps and you drag it back and forth. See all the swirls? That tells you this was a drag. You do this in situations when you think there will be a high likelihood of shedding of the diagnostic cells. You did a drag, and this one absolutely performed a drag. Very, very good. Dr. Gilbert, going back to the prior case, points out that the eponym for the CNS-PNS junction is Oversteiner-Redlich zone. Yes, very good. Okay, let's go to higher power. Okay, well, I want you to study this drag. Study the drag, and then I'm going to ask you for a differential diagnosis. And I have about 4 images, different fields, up to high power, so you have a fair shot at it. Everyone understand? All right, here we go. A little bit higher power. Okay. Higher power. Another one. Single cells. By the way, I didn't say it. This is the single cell smear pattern. Another one. Okay, that's the last histology I have. So here we go. Differential diagnosis. All right. Sergio Pino Oviedo. Yes, very good. Sergio says melanoma. Okay. What else do we have? Matab. Very good. Dr. Tarani says melanoma and epithelioid carcinoma. Yes, Dr. Harb. Lymphoma. Okay, whoa. Now that I would follow that up with what type of lymphoma would this one be, where you have tiny cells going up to giant cells. All right, and then Dr. Harb also nailed the diagnosis. I'm going to hold off on that. Plasmacytoma. I like that, Dr. Gilbert. Again, I think we need to go back and let's just see, when you're looking at that, do you think that's really good for plasmacytoma, for lymphoma? I'm just saying. Okay, now maybe you are answering the question, what's the differential for single cell? That was probably it. I want a differential diagnosis for this tumor, okay? This tumor using all the data. Got it? Yeah, that's better. Okay, very good. Here we go, differential diagnosis. I'm going to show you the FFPE. All right, here we go. Formalin-fixed paraffin embedded tissue. Here's another one. All right, you can still see the single cells there. Can you appreciate the epithelioid? Yeah, basically what I'm asking is the differential diagnosis for an epithelioid neoplasm, isn't it? Okay, and then here's more FFPE, and I think this was the, that's the last. Okay, very good, Dr. Gilbert. Here we go, pre-op imaging. I'm even going to show you the pre-op imaging. Here it is. What do you think? You like that? And there's a sequence. So you have CT scan far left, which is showing hemorrhage. We've already seen the brown pigment. Question that brown pigment. 3 major possibilities for that brown pigment. Let's go back. All that brown pigment. Possibilities: hemosiderin. If it was more orange, that would be hematoidin, which is hemosiderin without the iron. Melanin pigment. Not in this particular case. You can think of pigmented fungi. There's formalin pigment. Whole differential diagnosis. But here we're talking about either hemosiderin or melanin or both. Like in metastatic melanoma, they tend to be hemorrhagics, so you may have melanin and hemosiderin. Actually, it's more common to have hemosiderin in metastatic melanoma than melanin, because well over half, maybe 2/3 of metastatic melanoma in the brain, they don't make melanin. No melanin you can detect on H&E. Okay, anyway, pre-op imaging, there it is. On the CT and also on the T2 star, which is the gradient echo, you can see blooming, and this is the hemorrhage, and see that beautiful correlation. Now, usually it works in reverse, right? We see this first, we see the CT, and we see the gradient echo. We put all these together, and then we say this is going to be a hemorrhagic tumor. And then you think, well, what are the hemorrhagic tumors? So what's our differential? This is one Venn diagram, data sphere. It's a pre-op imaging, and one of the subparts of that sphere would be hemorrhage. And so we think hemorrhagic tumors. The things that come to mind: melanoma, renal cell, glioblastoma, just because it's so common, they can present with that. Anaplastic oligodendroglioma can present as more talking about lobar hemorrhage, mimic lobar hemorrhage. Dr. Gilbert, choriocarcinoma, they're virtually all hemorrhagic. I have seen, I think, 2 this past year. That's it, just 2. So it's rare, but they definitely hemorrhage. All right, differential diagnosis. We get all the bets are in. All right, we've already covered it. Okay, this is epithelioid glioblastoma, BRAF V600E mutant with a hemorrhagic clinical presentation. Yes, there we go. The differential diagnosis, everyone did fantastic on this, everyone. The differential for this smear, is melanoma number 1, absolutely. Epithelioid carcinoma, all right? Breast can do it, lung can do it, almost any carcinoma can do it. I've seen it most common, I think, with breast and lung. Epithelioid glioblastoma. Do not forget epithelioid glioblastoma. Okay, quick question. What if on the presentation, say this patient, this tumor, what if there had been 2 lesions, right frontal lobe, left occipital lobe, contrast enhancing, hemorrhagic? Could you then eliminate epithelioid glioblastoma? No, because it could be multicentric glioblastoma. Has that actually ever happened? Yes, it happened to me. The surgeon was, I believe, Dr. Jeff Weinberg at Frozen. He took out 1 lesion at Frozen. Dr. Weinberg's one of the neurosurgeons, one of our wonderful neurosurgeons who scrubs out a lot to come in and look at the Frozen with the pathologist. Everyone speaks everyone's language at MD Anderson's the way we work it. And we're looking at his epithelioid tumor. And I said, you know, I can't tell. There was no pigment. I said, it's either going to be epithelioid carcinoma or melanoma. I can't tell which. We use the markers. And he said, but it's not glioblastoma. And I said, right, it's not glioblastoma, because I was being influenced by epithelioid morphology in 2 lesions in completely different parts of the brain. It was epithelioid glioblastoma. We published it. Can you tell that had to have been 20 years ago, and I remember it like it was yesterday because I failed, and I failed in front of a neurosurgeon. Now it did not hurt the patient. Did exactly what would have done under any other circumstance, but it was very embarrassing. But I've never forgotten it, and I'm passing it on to you. Yes, yes. Okay. Let's do histologic image of the week. Yeah, there is beauty in the images that we see in radiology and in pathology, and sometimes they just capture your imagination. All right. So this is smomatous meningioma, and look at that in the center. You see 2 forms of calcium salt deposition. There's actually 3 forms of calcium deposition in meningiomas. Psammoma bodies, which form inside the whorls, right, and they're always concentrically laminated. Then there's dystrophic calcification in fibrous meningiomas of the collagen bands, and that's what you're seeing here right in the center of the field. It is the mineralization of the collagen, and they actually have collided. So I guess you could call this a mineral salt collision mass, right? So that they've grown into each other. You know what this suggested to me the minute I saw it? It looks to me like a B-52 bomber. B-52 bomber coming straight at you, right? So that's the fuselage with the nose cone coming right at you, and then these big giant wings coming at you. So the right wing is on the left. It's still got its engine. This is war, so the left engine has detached. Okay, well, you're using your imagination. That's a pretty cool photo, isn't it? Here's just another shot, again, showing the collagenous mineralization. And these are always going to be linear spicules, all right? Those are 2 forms, psammoma bodies and dystrophic calcification in the collagen, linear. What's the 3rd form? The 3rd form is one of the forms of metaplastic meningioma, osseous metaplasia, bone formation within the meningioma by the meningioma cells. Yes, you don't see it very often. This case actually had it. One slide had 1 focus. Yeah, in other cases it will be more obvious. Virtually every tumor has a metaplastic form or can show what we call heterologous differentiation. You know, something goes haywire and one of the cells, a clone, says, you know what, I'm going to start making matrix or producing fat or whatever it is. And we see it all the time in pathology. And it's always one of those things like, wow. And you take a moment, you pause for a moment when you see that to admire it, to think about it, what was going on with the biology, with the molecular biology to generate it. Anyway, I thought it was worth capturing this and bringing that to you. Okay, and I also, I'm going to drive this point home again, even though I've already showed you a beautiful gross photo of that lumbar cistern schwannoma. Let's do a microscopic photo of the week, and I'll start by showing you the imaging. So here's the tumor. You can see T1 with contrast on the far left, and T2, native T2 in the middle, and then we have a sagittal T2, and then a coronal T2. You can see pretty much massive vasogenic edema. It is respecting the gray-white junction, and you can see it's a dural-based mass. The mass was resected, so you're ready for the gross photo of the week. This is actually 2 weeks ago, all right, after I'd done the last conference, so it's legit to include. Here's a gross photo. What's interesting about this? Now everyone's thinking meningioma, correct? What's interesting about this meningioma? The color is interesting. It's yellow, yes. Good job, Dr. Gilbert. It's yellow. What's your diagnosis? Let's have a diagnosis. Here's some histology. I got metaplastic from Dr. Trivedi. Yes, what type of metaplastic? Okay, oh, Dr. Gibbs weighing in with hemangioblastoma. Oh, look at all these vessels. What should be in your differential with all these vessels in addition to hemangioblastoma? And also, quick question. Dr. Gilbert's going for the zebra, and we do see them. Listen, how common is isolated solitary hemangioblastoma in the supratentorial compartment? Even in von Hippel-Lindau, it is exceedingly rare, and sporadic even rarer, but that doesn't mean that I won't show you one in this conference. And it absolutely has to be in your differential, but what goes to the very top? All right, Vanessa Marino, yes, angiomatous meningioma, for sure, and of course, Sergio Pino-Oviedo, University of Arkansas, who is half neuropathologist, half hematopathologist, lipomatous and angiomatous meningioma, done and done. Look at the vasculosclerosis, chronicity. Look at all that collagen, chronicity. Look at those vessels. Isn't that amazing? Oh, what else do we see here besides these collagenized vessels that are all growing together? What is that? What's that? Oh, look at the other area. Hey, is this trying to mimic hemangioblastoma or what? It is trying to mimic. All right, well, what tumor can mimic that? Well, angiomatous meningioma with lipomatous differentiation. All right, here we go. This is what we're talking. Now, look at those nuclei. Okay, quick question. Are these just macrophages? Macrophages in the... well, no. Look at the nuclei of the cells. The nuclei are the same. They are identical to the meningioma nuclei in the cells that are not undergoing the lipomatous metaplasia. All right, here's lipofilin. Look how these are little membrane-bound vesicles, all right, of fat in the cells. How gorgeous is that? Isn't it wonderful to have all this immunohistochemistry to bring it up? Yes, that is beautiful. Just think about what that looks like ultrastructurally through electron microscopy, all of these little vesicles, and we can visualize every single one of them with lipofilin. Isn't that fantastic? Yeah, it is. All right, so here we go. This is the whole thing, and this is where, if we hadn't already been talking about it, I would ask for your diagnosis. Okay, what is the actual diagnosis? I mean, look at that edema. Look at that edema. So this has got to be atypical or anaplastic, right? No, grade 1. Grade 1 meningioma. Look at the mitotic index, H&E, less than 1, fewer than 1 mitosis. Mitotic 1 mitosis even with phosphohistone H3. Mitotic figure immunostain, just 1. Ki67, 1%. Yeah, it's a grade 1. Look at that interface. Interface is pretty short. Well, but wait, hang on. Something's not right here. With this edema, and it's grade 1, did we miss the brain invasion? No, I had the whole thing. We had the whole tumor. We had the surgeon, the neurosurgeon took it out. It came out. There was no violation of the PIA. There was no problem. There was no brain invasion. How was it confirmed? By direct visualization of the neurosurgeon. Talking to the neurosurgeon is the best way to go. We've got Kristen Huntoon tuned in this morning. She can address that. Talking to the neurosurgeon is the best. Reading the op note, if you can't talk to the neurosurgeon, is the next best thing. Read the op note. In cases where you're wondering, there is a wealth of information in a detailed op note for the pathologist and for the radiologist who is interested in follow-up. How did I do? How did I do in that case? Hey, listen, radiologists, listen to this. You know what I do for, all the time, we will get pathology in for patients that will not be seen in clinic for a month. And so the path comes, they have not sent the imaging on CD, so there's nothing in Epic, or maybe it's taking time, for the text to upload it. But I have to issue my report, and it's a really interesting lesion. And I think I really wish I had the pre-op imaging, but I see that the patient's coming to clinic in a month. So you know what I do? What I do is I go to my calendar, and I just make a note a month in the future on the day, usually whatever the day or close to the day of the clinic appointment. I just put a note, and it says check MRN 463241, and a little note, meningioma, meningioma question, invasion, something like that. That way, I get it. I get the follow-up. Radiologists, you could do exactly the same thing. You have an interesting scan, right? The patients will not go to surgery for another week or yada, yada. Now, for the controversial cases, you're absolutely going to know they're going to be presented tumor board, et cetera, et cetera. But sometimes it's not that dramatic, but you just want to know. Well, make a note in case it's not on tumor board or the neurosurgery conference. Just make a note, check MRN, and put it for a week out or 2 weeks out. Path report will be done. You like that? Yeah, absolutely. And listen, for radiologists and for pathologists, those of you who are interested in academic medicine and you're going to be giving talks, start building your teaching sets now. And it's so inefficient. Like the week before you have to give a talk to start searching through all these files and searching MRNs and yada yada to try to get examples. Build it day by day by day. I do this every single day. I save things, MRNs from different images, histology, radiology, etc. So when the time comes, I am ready. All right. This is just a word to the wise. It's one of the tricks. Let's look at the comment. We're not done yet. H&E stain sections show a highly vascular meningioma, angioma verite, with prominent diffuse lipomatous metaplasia, confirmed by lipofilin immunostaining. The extensive lipomatous metaplasia explains the golden yellow gross appearance of the meningioma. I actually had, you're not going to believe this, it's the truth. Over the 2 weeks, over these past 2 weeks, I had 2 lipomatous meningiomas. 2. I'm only showing you one. All right. Large areas of the tumor composed of fields of fused, densely hyalinized sclerotic vessels. The area showed dystrophic calcification, consistent with pre-op imaging. Mitotic activity not really identified on H&E. Manually quantitative uses in-phase immune marker PHH3, yada, yada. Pathologists, hey, pathologists, listen up. 10 high power fields, HPF, not good enough anymore for the forthcoming 5th edition of the World Health Organization classification in terms of the nervous system. We're going to have to put in the 0.16 square millimeters. Technically, you should be using, micrometer, standardizer stage, et cetera, because, the high power fields can vary from scope to scope to scope to scope. This is how you can handle it. This is how you can handle it. Instead of saying 1 mitosis per 0.17, you can still say for HPF and just put it in there like I've done. This is just one solution, right? Okay, and then you're covered. Okay, concurrently, computer assist, automated quantitative use KI, yada, yada, no atypical features. All right, here we go. The diagnosed angiomas meningioma group imaging show a dura-based contrast masking, focal calcification, accompanied by marked vasogenic edema of the adjacent brain. Teaching moment. Angiomatous meningiomas, similar to secretory meningiomas, are frequently accompanied by marked brain edema, right? This is nothing new. It's in the literature, but unless you've encountered it, maybe you read it in a book, you read it in the paper, but you've never encountered it, so you're not expecting it. Now, everyone tuned into this conference, you will expect it. You will expect it in the future now, yes? Okay, now, I told you that I had two lipomatous metaplastic meningiomas over the last 2 weeks. But would you like to see a gross photo of the most impressive one I ever had? This is going back about 15 years. They're not that common. 15 years ago, I had the 4-leaf clover of lipomatous meningiomas. Stunning. Are you ready? That should, if you're a pathologist, that should take your breath away. Isn't that just amazing? That's the dura, and it is bright yellow. Okay, hey pathologists, here's a quick footnote. Pathologists, do you notice all these little slices? Did I do that? Of course not. A fellow did it. Okay. I put it back together the best I can, and it's still massive. The fellow beat me. This was not a neuropathology fellow. This was a general fellow. Beat me to the frozen section room and had bread loafed the thing before I got there. And it's like, oh my goodness. See, now look, here's the point. Why would you bread loaf it anyway? I don't know. And I don't remember who it was, and that's a good thing, right? Because we don't want to become embittered, you know, as we go through life. All right, look at this. So how about that? Isn't that just dramatically beautiful? Okay, anyway, yeah, that was the best one I've ever seen. Yeah. Okay. Let's do molecular signature differential diagnosis warm-up. I know everyone's thinking, when are we going to get to the cases? We're going to get to the cases, all right? All in good time. We've got 16 minutes. All right, molecular signature differential diagnosis warm-up challenge. All right, I want a differential diagnosis. Are you ready? Here we go. Just give me the most likely possibility, and what we're looking at, this is the immunostain is ATRX, and I'm giving you also the T2, an axial T2, and I just want, give me a differential, okay? From Chris and Huntoon, I've got INC4A, susceptibility to imaging, I've got this, what's a differential? There's something I want you to see. Think outside the box. Pathologists, you better get this right. I don't think the radiologist surgeons can, Matab Tarani, Dr. Tarani, yes, it did not work. Giselle Lopez, good job, repeat the ATRX. No, your differential, Sergio Pinoveta, not working, yes, very good. The immunostain didn't work. The endothelial cells and normal glial cells, which should be scattered throughout, this is diffuse glioma, are not showing wild type expression. So that was what I wanted you to see, as opposed to say, you know, astrocytoma, oligo, anything like that. I wanted you to see, call to my attention, the immunostain didn't work. Here's another, I took several photographs of this, of the stain. This is not an MD Anderson stain, by the way. This is, quote, from the outside. Everyone see that beautiful, delicate vessel just right in midline with the linear endothelial cells, stone cold blue? Yeah, the HRX. Look, what you would have to know, in order to get this right, you would have to know that the antibody directed against ATRX is directed against the normal wild type protein, an epitope of the normal wild type protein, not a mutant protein. And what you're looking for is loss of ATRX due to mutation or some other modification. It does not have to be mutation. Loss in the tumor cells with retained wild type expression in the endothelial cells and scattered glial cells, microglia, neurons, right? That sort of thing. All right, here's this is another one. See that little cluster of vessels to the right side of the screen? You can see the red blood cells, no staining at all. All right, that's just a technical point. All right, anyway, this is a subtlety. This is what pathologists have to know. We have to have an eye for that. Is there an equivalent in the radiology world? Oh yeah, you know there is. Absolutely there is. There's all sorts of subtleties in terms of interpreting sequences. T2 shine through would be one great example. All right, I'm saying we got to be cautious, et cetera. The different, not only different sequences, the different instruments. Some of the instruments are better than others at specific perfusion metrics. For example, you can't rely, you know, so that's the granularity that an expert, like an oncologic neuroradiologist, knows about neuroradiology. And it's going to take us, pathologists, a lifetime. We don't have to master that or even get fluent with it, but we have to master the same level of granularity with histology, which is picking up things like this. Okay, hey, I think we're warm now. We are warm. So let's take patient number 1, 32-year-old male. Start with the histology. All right, I want you to make observations about this. Okay, and I'm going to show you several more images. I'm going to ask you for your differential diagnosis, or just a diagnosis, the most likely diagnosis. You can go ahead and chime in if you want. Dr. Trevay, oligodendroglioma, I am liking it. Dr. Cathcart, oligodendroglioma, yes, Dr. Zinarelli. Here we go. That's neat. Okay, diagnosis. Okay, I think everyone is on the same page. Let's look at the imaging. There's the imaging. All right, good. Are we good to go? Is the diagnosis oligodendroglioma? Dr. Harb says no. No, we're not good to go. We are not good to go. Dr. Gilbert nailed it. Happy with this for oligo? No. We call this a T2 flare mismatch sign. The T2 flare mismatch sign is, for all intents and purposes, 100% positive predictive value for IDH mutant diffuse astrocytoma. Yes, this is an astrocytoma. Now you're saying, but wait a minute, it looked like classic oligo. I thought histology was always correct. No, that's why molecular signature will always triumph over the histology. Listen, classical oligohistology, including, you saw those microcalcifications, is about 85 to 90% accurate in predicting oligodendroglioma. 85 to 90. That's huge. It's wonderful, but it's not 100. What about the 10 to 15%? Now, I'm not talking about mixed oligoastrocytoma. I'm talking about tumors that look like, just like the one I just showed you, look like oligo. I mean, it's like, you know, Alex Perez was neuropath fellow that has been on with me up until recently for like 3 months. And there was 1 week, Alex will remember this, when he brought the cases. He'd already worked up the cases, and I think it was 3 in a row, 3 gliomas in a row, and it was like playing, you know, Queen's Gambit speed chess. You know, I take one look and I put it out there, and I said, "Is it oligo?" And he just smiled and shook his head. No, 3 in a row that I was going with oligo because the halos and the calcification. That's why there's always a differential, and diffuse glioma is always your best bet. All right? Okay. Would you like to see the molecular diagnosis? Here's the molecular signature. What do you see? Classic triad of IDH mutant diffuse astrocytic disease. IDH mutation, TP53 mutation, ATRX mutation. Here's the final diagnosis. AA, IDH mutant, grade 3 by the WHO 2016. Just astrocytoma, IDH mutant, grade 3 by CIMPACT now, which will be adopted by the 5th edition of the WHO. When it comes out, it looks like, I think at this point, I've been calling it WHO 2020. I think we all thought it was going to be 2020. It looks like it's going to be 2021 now. That's okay. Getting closer. I think I'm going to change all my slides to WHO 2021. Here we go. Let's do a quick language watch. Let's take a break before we get to our last case. Language watch. CK7, this is from a pathology report. CK7, CK20, TTF1, CDX, melanoma cocktail, which HMB45, tyrosinase, MART1, that's MD Anderson, SOX10, and PAX were performed. Okay, here's your question. Is there tyrosinase in the MD Anderson Cancer Center melanoma cocktail? Is there tyrosinase in the melanoma cocktail? This is a simple question, yes or no. Why aren't people texting? No one's texting. Okay. Darshan Trivedi says no. Well, wait, well, look, I'm showing it to you. I'm showing it to you. No. You're not looking at this correct. Everyone's missing it. I'm not, what would it matter? Why would I ask such a trivial question about MD Anderson when with only maybe one or two exceptions, none of you are at MD Anderson? Why would I do that? No, there's no tyrosinase, but this path report says there's tyrosinase. What's the key? What's the point? What am I getting at? I'm talking about precision in language, accuracy in language. This is slang. It's slang. It's path slang, and we all do it, but you need to recognize it's slang. Only one of the 3 melanoma cocktail ingredients is actually in the cocktail. Only one. Which one? HMB45. Yeah, HMB45 is actually in the cocktail. What's HMB45? What's MART1? What's tyrosinase? Well, let's go to pathology outlines. All right, and here we go. All right, Dr. Chen. We see this is melon A or MART1, melanocyte-specific cytoplasmic protein. In the formation stage 2 melanosomes, melon A was discovered as an antigen. Cytotoxic T cells, what does it stand for? Melanoma antigen. J. Experimental Med, 1994. Same gene independently identified by a different group. They called it MART1, melanoma antigen recognized by T cells. Ooh, PNAS, high impact journal. So melon A, MART1, same thing. Pathologists know this. All right, and then it goes on to say yada, 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 yada. Look at essential features. This is a marker more sensitive than HM45. Look. What is it? Look at the second bullet. It is not an antibody. It is a cytoplasmic protein. Why would you put the protein in a cocktail? You're trying to detect the protein. You don't put the protein in a cocktail. What's HMB? Oh, that's an antibody. HMB45 is actually an antibody. It's in the cocktail. Yeah, there we go. HMB45. Human melanoma black, discovered 1986. American Journal of Pathology. It's an antibody. Yes, precision language. All right, have a look at this. Is a different path report. Examination of additional tissue levels, immunohistochemistry study paraffin sections, anti-melanocytic cocktail. Ready? You ready for it? HMB45, anti-MART1, and anti-tyrosinase. There's no tyrosinase in the cocktail. It's actually an antibody directed against tyrosinase. Look at the precision of this language. This was one of our fantastic dermatopathology fellows that typed this up in one of the attendings, and they tend to be really smart. because a lot of the dermatopathology fellows go on to enter private practice where they can compete with neurosurgeons in terms in terms of income. All right, isn't that nice? Do you like it? Now listen, look, that's fine. I'm not disagreeing. We all the time we say GFAP, positive for GFAP. All right, we say the antibodies GFAP. Yes. I just want you to know the difference. You know, the nomenclature for antibodies in pathology, it's a mess. It's an olipodrita, right? Everything is in there. Some are actually antibodies. Some are catalog numbers. Anyway, all right, we got to move on. Patient number 2. Okay, this is our last case. All right, here we go. It's actually not the last case. I'm going to make it the last case because we're going to respect the time. I did have one more case, and we will look at that last case. I will save that for the next conference. The next conference is going to be on Friday, December 4, and I'm going to move it back to 3 p.m. on Friday. I'll be working from home, and so that's what we're going to do then. Listen, you just have to watch the announcements. This COVID thing, it is a work in progress. My schedule. You know I'm on service for January. No, not a week in January. I'm on service every single working day in January because, you know, we lost 2 of our senior neuropathologists to retirement, and so now it's just me and Dr. Hughes, and Dr. Hughes runs a lab and has his hands full. He's capped 20% max, so I am on service every week in January, but this conference will continue. All right, patient number 2, let's finish up. 71-year-old male with metastatic melanoma. Here we go. Now I'm showing you on the left is the pre-stereotactic radiosurgery. On the right is the post-stereotactic radiosurgery. What you see, this metastatic melanoma, does everyone see the 2 lesions? There's one supratentorial and there's one in the 4th ventricular region infratentorial. Everyone see the lesions? What is the difference in pre and post-stereotactic radiosurgery? Look at the supratentorial lesion. You see, it shrunk by about half. Not only did it not grow, it's about half the size, and the edema is gone, right? Which would be hypointensity on T1, right? That's magnificent. Look at the 4th ventricle tumor. It's virtually unchanged. No change. No increase, no decrease. All right, this is a problem. So what was the decision? There was also another lesion tree. The decision was send in the neurosurgery. Let's bring in the Calvary, take it out. All right, it was taken out. Ready to see? All right, you ready for melanoma? Here we go. Impression. Someone give me an impression. This is the tumor. I will say this is what was resected. This is what was resected. Kristen Huntoon, yes, not melanoma. Okay, very good. Andrea Gilbert, not melanoma. All right, yes. Andrea Gilbert, Rosenthal fibers. Darshan Trivedi, subependymoma. Darshan. Zainab Harb, subependymoma. You're both right. You're both right. Okay, what are we seeing here? What we're seeing here is normal brain. This is normal brain with reactive Rosenthal fiber formation. That's what all those bright red things are. This is what we call pyloid, which means hair-like, pyloid gliosis with Rosenthal fiber formation. What are Rosenthal fibers? They are compacted GFAP filaments with a bunch of entrapped cytosolic proteins. So they stain with virtually every immunostain that recognizes cytosolic protein, they'll stain for it. But it's basically made GFAP. All right, here's just another field. See all the Rosenthal fibers. Look at the hyalinized vessels. There's some hemosiderin. Look at those. Is that beautiful or what? So this is what does it tell us? It tells us chronicity. Chronicity. It's this tumor in the 4th ventricle is not melanoma. It has, you know, the metastases in this patient have been there maybe a month max. No, this tumor has been there for years. Yes, what do you think? Rosenthal fiber formation, not metastatic melanoma. Here's the frozen. Dr. Trivedi, I think, was the first to say it. Subependymoma. Look at the clusters, lobules, clusters, lobules. There we go. Here's the FFPE. Look, see, big lobules, right? It almost looks like the blood vessels and the psammoma bodies, you know, that grew together. That's sort of what subependymoma looks like. And within each lobule is a smaller cluster, and there it is, abundant fibrillary matrix, very benign, bland glial cells, usually no mitotic figures at all. Oh, look at that, writ large. Is that gorgeous? Bland nuclei, classic subependymoma, and there is, there's a report. Okay, I tell you what, I've got 6:58. I did have a couple of classic little things that we were going to do, and then the last case. But I want to stop because we're coming up on the 8 o'clock. Everyone I know has things to do to get to work. 6:59. The next conference will be Friday, December. I think will be Friday, December 4. Keep an eye on the email. If I'm able to do a conference before then, you will get an announcement. I'm going to stop with that, and I just want to say thank you. Thank you so much to everyone for coming to the conference. Awesome. Have a great day. And I guess we're going to call this the weekend. The weekend is coming. See you December 4.